Hello, everyone. We hope you are enjoying our lovely tunes, and thank you for those of you who weighed in and said thank you for the nice music. Well, welcome to Sylvester Comprehensive Cancer Center's Lifting Up Cancer Awareness Open Forum in conjunction with the GO2 Foundation for Lung Cancer. I'm health journalist Ileana Bravo. I will be your moderator for this evening's program. You were listening, by the way, to those dulcet sounds of professional jazz musician and Sylvester leukemia and lung cancer survivor Joe Scott. So tonight, we're here to shine a spotlight, to bring awareness to lung cancer, to also take the time to honor our patients and to offer you an opportunity to learn more about the latest advances in lung cancer treatment. This is also intended to be an open forum, so it's your opportunity to ask questions directly of our stellar panel of experts from Sylvester Comprehensive Cancer Center. Now, many of you have submitted questions in advance, and we thank you for that. We have them all loaded up and ready to ask our experts, but you have plenty of time. Look at the Q&A feature, that toolbar at the bottom of your Zoom screen, and that is where you have a right and hopefully will be interactive in putting in questions, but we also ask you to be sensitive to protect patient privacy and don't ask very personal questions and nothing specific about a treatment or a case. You'll enter those questions and we are going to tee them up for our experts throughout the evening. And we'll also be asking you poll questions, and that is also to get an idea of the demographics and the profile of the people who are there with us this evening. So again, do your part and participate and answer those questions. So here we go. First poll question of the evening to get a sense of the audience. And that is, how would you classify yourself? It's going to pop up on your screen so you have choices. Are you a patient? Are you a caretaker, an advocate, a provider, or other? Just check one of those boxes, how you would classify yourself. I'm going to wait a few seconds to give you time to gather yourselves and take part in our discussion for this evening before I introduce you to our panel of experts for tonight. Let's see how we did. Okay, 80% are patients and the rest, a small amount of others. So that gives us an idea to our experts whom I'm about to introduce, who you're going to be speaking to tonight. And they begin with Dr. Estela Mari Rodriguez, thoracic medical oncologist.
Hi, good evening. Delighted to be here.
Dr. Richard Thur, a thoracic surgeon. Thank you for joining us.
Thank you.
Dr. Richa Dewar, a medical oncologist specializing in lung and breast cancer.
Good evening, everyone. I'm happy to be here.
Dr. Rafael Yachieli, who's a radiation oncologist specializing in lung cancer.
Really an honor to be here. Thank you.
Dr. Nestor Villamizar, who is also a thoracic surgeon.
Hello, thank you for having me.
And last but not least, Dr. Asma Aftab, Director of the Tobacco Free Florida AHEC Cessation Program at the University of Miami.
Good evening, everyone. Delighted to be here.
Welcome to all of you and welcome to those in the audience who are with us this evening. So let's just jump into answering some questions from the patients. The first question is about clinical trials. Are there clinical trials for lung cancer patients and where can I call to learn about them? Dr. Rodriguez, why don't you take this one?
Great, that's a great question. So most of our clinical trials are organized at the time that you go visit your physician. So a lot of the trials that we have, you can find them in our website at sylvester.org. And you can search by thoracic oncologist and you'll get a list. There's currently 26 trials that we're enrolling patients, and trials come in many different types. We have a very large, actually the only large phase 1 program in this area. So those are drugs that are on development that haven't been approved by the FDA. And we're happy that we have that through our NCI designation. We also have a lot of phase 2 and phase 3 trials, which are drugs that we already know the right doses and we're testing in patients. And we're just proud to tell you that many of the new developments on lung cancer, those trials have been done at Sylvester in phase 1 and phase 2 trials. Just this year, since March of 2020, it's been a horrible year for many things related to COVID, but for lung cancer, there's been a lot of new developments. 9 new drugs have been approved with new indications, and some of those trials have been at Sylvester. So when you meet your doctors, you'll have an opportunity to talk about trials. It is our goal that every patient that comes through our door gets offered a clinical trial, and we work very hard to, in our pipeline, to keep upgrading the list and opening ourselves to new trials so that we can offer patients new options.
Thank you, Dr. Rodriguez. And I remind those of you who are just jumping onto our Zoom forum tonight, we're talking about lung cancer awareness. We have an incredible panel of experts from Sylvester Comprehensive Cancer Center. So let's jump to the next question on proton therapy. What is proton therapy and how can it be used to treat lung cancer? How about you, Dr. Kelly?
Thank you. That's a really great question. I guess I'm so excited I'll jump ahead even before getting introduced. So proton therapy is a form of radiation therapy. Now, we normally, when we treat with radiation therapy, and we'll talk about this a little later, we use photons. That's the most common way of treating. And photons have no mass, and they just kind of keep going, which we can shape it very well and use it very precisely. But protons actually have this mass, and the physics of it, you can reach out to me behind the scenes and we can talk about it. But because of its weight, it has something called a Bragg's peak. And that means that the radiation stops. So we can use it in scenarios where in the past we really were limited. So for example, we can protect the heart much better than we were previously able to do, to deliver much less dose of radiation to the heart or other normal structures. The place where this matters the most is probably in patients who unfortunately are dealing with recurrences of lung cancer, where in the past it was very difficult to offer them definitive type treatments, but now with proton therapy, we're really able to offer much more and very, very advanced treatments that we were previously not able to offer. And this is, it's a huge gain. And the fact that we're able to offer this for our patients at Sylvester really ups our game for our team and our patients. And it's a big deal. So.
Great. Important information. And I remind all of our audience members that the Q&A feature located at the bottom of your Zoom screen, it's got two little thought bubbles. It says Q&A. That's where you're going to enter your questions for our experts tonight. So let's move on to, let's see, what's the next question for Dr. Villamizar. If you're told you have a pulmonary nodule, to which specialist should you be referred?
I think that the two specialists that are better qualified to evaluate the lung nodules are probably the thoracic surgeons and then the pulmonologists. The most important thing for us is when we are able to compare a CT scan that shows the lung nodules with a previous CT scan. That's when we can really have kind of like an idea about what we need to do with these lung nodules. Not every lung nodule is cancer. So there are many reasons why people can have lung nodules. The majority of the lung nodules are actually not cancer. We see many lung nodules, for example, associated with reflux and things like that. So again, it's important, to go through the whole process of kind of asking a complete history of the patient, if the patient has had cancer somewhere else, the exposure to, the different environments and things like that, traveling, recent infection, all sorts of things. But I think that either a pulmonologist or a thoracic surgeon would be able to sort that out.
Okay. Here's a poll question to see how much our audience is looped in on these things. And that is, can people who have never smoked get lung cancer? Up on your screen is going to come up the choices of yes, no, or I'm not sure. Can people who have never smoked get lung cancer? And I'd be interested to see how much people know and whether our experts can weigh in once we know from all of you what the real answer is and what the truth of the matter is. Can never smokers get lung cancer? Wow. Everyone knows what they're doing tonight in our audience. They said 100% said yes. Would any of you like to comment on that?
So I will comment that we definitely have seen a rise of cancer in never smokers. And the good news is that we're understanding more of the why. So we know that many of non-smokers, never smokers with lung cancer have specific mutations that they're not born with. There's somatic mutations that they develop later on. And there's about 9 mutations that have been defined, many of them in never smokers or very light smokers. So when you have symptoms for lung cancer that are cough or shortness of breath are not getting better, it is important that you get follow-up because we are diagnosing cancer on patients who are younger, who we didn't expect them to develop lung cancer because it's not associated with tobacco. The other point I would make is that many of the never smokers that get lung cancer are women. So if we look at women that get diagnosed with lung cancer, a lot of them are never smokers, and we don't understand exactly why, and we're actively doing research on that. But it is important that if you have symptoms, again, go to your doctor until that gets addressed and resolved.
Wow, that's interesting. Women then perhaps in the genetic mutation issue. All right, let's jump to this poll question. Who's a candidate for lung cancer screening? Age 45 or older with any smoking history, age 55 to 80 with a 30-pack a year smoking history, or any age with a strong family history of lung cancer. So this will definitely be interesting to see how much we know. I'm not sure that most of us would know that answer. And let's see how well we do. And Dr. Thur, maybe you'll weigh in once we see what our audience believes to be the truth. Well, who is a candidate for lung cancer screening? And that's interesting. So I believe that the correct answer is age 55 to 80 with a 30-pack a year. And yet only 30% got that, and another 26%, and 44% any age with a strong family history of lung cancer. Dr. Thur, what do you have to say on that?
So screening is designed for people who are at high risk for lung cancer. And that's defined today simply by a smoking history of 30-pack years, which is either 2 packs a day for 15 years, 1 pack for 30. Do that calculation between the ages of 55 and 80, and who and who are either current smokers. If they stop smoking 15 years prior, then they're not thought to be in a high-risk group. Now, this by no means catches all lung cancers with these screening programs, but this characterization of high-risk folks yields more benefit than harm in a big population group. I should emphasize that screening is for healthy people, not folks with respiratory symptoms. If you have chest pain, coughed up a little blood, have a cough of any kind, then you're no longer a candidate for screening, but for clinical care. And you should consult your primary physician and discuss the potential benefit of having a CT scan. But that's not no longer screening, that's providing clinical care for respiratory symptoms. But in the group of people who do qualify for screening, it's been demonstrated that the risk of death from lung cancer is substantially reduced in that population. I should also reemphasize what Dr. Villamizar said, that a large proportion of people who undergo lung cancer screening will have some abnormalities on the CT scan. And one needs to be prepared for that eventuality. And again, be prepared for further follow-up and further care.
Okay, I know. It's the real world. We're all live.
Perfect timing. My daughter, who I haven't seen in over a year, is checking in with us. It's
Wow.
part of the situation we find ourselves in.
No, no question. Dr. Rodriguez, you're nodding a lot. Would you like to weigh in on any of this and expand?
Yes, you know, so I mean, it's a great point. Thank you, Dr. Thor, to describe the program and the importance for people who have a smoking history or have family members who have a strong family history, that don't be afraid to go in and talk to your doctors about screening. You will get a low dose CAT scan with less radiation in an annual basis for 3 years. And then the task force that decides screening for Medicare this year submitted a new proposal that we start doing screening on patients that have a 20-pack year smoking history. And the importance of that is that we know that we miss a lot of women who have a lower smoking history and develop lung cancer. And we also miss a lot of minorities who have very aggressive disease with very limited smoking history. So I think it's going to be important, and we hope that in the next year, those new proposals will be approved, because I think we'll be able to cure more patients if we detect cancer early. Again, it's important to, if you have a history, to talk to your doctors and not be afraid.
Okay, let's jump to this question for Dr. Dewar. I've heard about liquid biopsies for lung cancer. What are they, and where can I get one?
That's a great question. So, as you all know, because of recent research and advances in technology, we now have liquid biopsy, and patients are more and more curious to know about liquid biopsy. But what is liquid biopsy? Everywhere you read about liquid biopsy. So for patients, liquid biopsy is a very simple test which can be done in your blood, and we can test the cancer cells, which is shedding from the tumor, or we can also check for circulating DNA shedding from the tumor. So if a patient has a tumor, and in this case, we're discussing about lung cancer, the lung cancer is shedding some cancer cells in your blood. It can also shed some circulating DNA in your blood. And with the help of this liquid biopsy, we can check for mutations in the blood by checking your cancer cells and DNA in the blood. It's a very important tool. And the reason is because nowadays, for any patient who have advanced non-small cell lung cancer, any oncologist, if you go to any doctor for your treatment, they won't be able to tell you the treatment if you don't have the mutation testing or if you don't have the molecular profile of the tumor. It's important to know at the first diagnosis what the mutations a patient have, because if you have that particular mutation, you are qualified to get targeted therapy. So that's one role. So it's very important. And then secondly, in many patients who come for treatment at initial consultation or second opinion, and if we need the tissue testing to look for mutations, the tissue is insufficient. The tissue is not available, or the tissue is insufficient. So if your lung tissue, the biopsy tissue, is not available for mutation testing, we can find the mutations in the blood. But we need to remember that the liquid biopsy is not 100% sensitive. If your tumor is not shedding any cells, any cancer cells in your blood, we won't be able to find mutations. And then we would need a repeat tissue biopsy. But it's very important if the tissue is not available. So it serves as an alternative method to check for mutations. And second, it has many utilities. And secondly, it's important, we can also check for resistant mutations in your blood. So let's say that if you're not responding to a particular treatment, then your doctor can check for resistant mutations to see why you're not responding to a particular treatment. And number three, sometimes a doctor can monitor your disease by checking the rate of mutations in your blood. So if you are curious about liquid biopsy, or if you're not sure if liquid biopsy is right for you, I encourage all of you to discuss with your medical oncologist. We have great medical oncologists at Sylvester. It's the only NCI designated cancer center in South Florida. So you should discuss this with your oncologist and ask if liquid biopsy is the right test for you. And you should know that in 30% of cases, the tissue is insufficient. So I think it plays a very important role nowadays in the management and also to guide therapy.
Good. And I remind our audience that, yes? That this is a very special forum, and it's for you, because we know that 100% of the audience members tonight are patients. So here's your chance to ask questions of our experts tonight, and use your Q&A chat box at the bottom of your Zoom screen in order to do that. We are here for until 7 o'clock, so there's plenty of time. So hear from these participants. I've tried to quit smoking cold turkey. I've not been successful. What else should I try? Dr. Aftab? You're muted, Dr. Aftab. Just unmute yourself. Give us a minute. Live TV.
Okay,
folks.
I'm sorry.
Yeah.
I'm so sorry. First of all, I would like to congratulate that patient who asked this question, just trying to quit tobacco. That's a huge advance towards good health. And I will, we don't advise cold turkey because all the research evidence tells us that the tobacco is the most addictive substance in the universe. And if you are trying to quit, and this is it changes the receptors in the brain for addiction. So it's a problem. It's not like something that you can you can quit like without any aid. So our recommendation is always that try to get help with the nicotine replacement therapy, because the receptors in the brain, trying to wean them off this addiction, you need something like nicotine to wean them off, because you are taking your nicotine for a very long time. But the nicotine nicotine replacement therapy that we offer is not the cigarettes, because cigarettes have other thousands of bad things in it. So we have these transdermal patches, gums, and lozenges with different strengths depending upon your addiction level and the packs of cigarette you smoke. And that can help you. They're available over the counter. They're available from our program. You can use them. Evidence shows that you will be very successful 70% of the time if you use the aids, the nicotine replacement therapies, in combination of the patches, the gums, and lozenges. And Tobacco Free Florida provides tobacco cessation group support programs, and also free nicotine replacement therapy for the participants. So any Floridian can join our program, and they can start on the journey of tobacco cessation.
Okay. And so that leads us kind of to this whole vaping phenomena. It's gone up and down. It's probably a little lower now than it was at its peak. But is that safe and considered as a smoking cessation tool?
Yeah, vaping is it started very slowly, but now it's getting real. The prevalence is increasing. Every year we see, especially the youth is using it more and more. We don't encourage vaping as a quit device, because first of all, the chemicals in the vaping, the chemical tobacco in the e-cigarette or vaping device have tons of chemicals in it, and we don't know even, because it's not been investigated fully as of now. Now FDA is trying to move on vaping and what's inside. And then what's the problem, especially for the youth, when they start vaping, it get transformed into the real tobacco, real cigarettes, which is more harmful. So and for anybody who is quitting, vaping is not advised, because you are again taking all those chemicals that you were taking with cigarette, minus the carbon particles of the paper that's burning. But with e-cigarettes or vaping, the devices are so unsafe. You must have heard about, they are exploding in the faces of the people who are using them. So the battery gets heated, because there are kind of substandard devices around, cheaper and not tested well, and they can be very harmful. Can give you body harm. But the vaping has tobacco. It's big tobacco that's making these vaping devices. They want to keep our population hooked on tobacco, and we totally discourage anybody using vaping devices, and especially the youth, because once they start, their brains are still young, and they get quickly hooked on tobacco and then to the real cigarettes. So vaping is not advised as a quit device. We can use pharmacological treatment as well as over-the-counter nicotine replacement therapies like patches, gum, and lozenges.
Yeah. Thank you, Dr. Aftab. I think so important to send that message home. And now, with all the different flavors of these
Yes.
vaping liquids, of course, hooking the younger population as well. So thank you for doing a definitive statement on that.
Thank
So
you.
folks, we have a lot of questions coming in, which is great, and we're gathering them for you. So in the meantime, let's take a quick pause to watch a little video from our Sylvester providers. They work every day to care for our lung cancer patients. And in honor of Lung Cancer Awareness Month, they released some lanterns to lift up awareness. Let's take a look and we'll be back.
This month, we're celebrating the Lung Cancer Awareness Month, and we are so proud and thankful to be part of your care team. And we're so hopeful for the future and the new treatments that are coming up.
This pandemic should not stop us from providing lung cancer screening. We must pursue our fight against lung cancer.
It's my honor to serve as a guide for new patients from when they're initially scheduled and beyond.
For us to hold your hand from your diagnosis to your treatment means the world to us. This past year has been remarkable in terms of the new treatments that have been approved for lung cancer, and there is new hope every day.
Every day we continue to see new advances in this space and new FDA approvals for the management of these patients.
To all our patients fighting lung cancer, I want you to know that it is an honor to be part of your journey. Our team at Sylvester Cancer Center is here to support you and your loved ones. I want you to know that you're stronger than you think you are, and it's that very strength that's leading us and all our efforts into cancer research to find a cure.
We are so very proud and thankful to be part of your care team, and we wish you the best.
Always remember that you are braver than you believe, stronger than you seem, and smarter than you think.
That's just great. Braver than you believe. Thank you, because you inspire our providers to be their best and to continue to bring awareness to lung cancer. So let's move on to another poll question to test our very smart audience's knowledge, and that is, how often should patients be followed after lung cancer surgery? Every 2 months until 5 years? Every 6 months until 5 years? Or every year for 5 years? And I know Dr. Villamizar is going to want to give us a weigh in on this one and give us his opinion on people's answers. Let's see. 70%, Dr. Villamizar said every 6 months until 5 years. What do you think?
I actually have a different answer than the ones that are there. It depends on the stage of the lung cancer. If you have early stage lung cancer that has been completely, what we think, cured with surgery, then the guidelines that we follow, which are the NCCN guidelines, would say that you should have a CT scan of the chest every 6 months for 2 to 3 years, and then every year thereafter. If the lung cancer is in a locally advanced stage, then we try to do those CT scans a little more frequently. So the guidelines would say, between 3 and 6 months for the first basically 5 years, or more frequently early on, like for 3 years, and then you can schedule like 6 months, year 3 to 5, and then every year thereafter. For me, we know that somebody who has had lung cancer is at a higher risk of acquiring what we call a secondary primary lung cancer. So the principles of lung cancer screening should apply for people who have had lung cancer in the past. So even after 5 years, they are still at risk, not on necessarily that the same cancer that was removed is going to come back, but to acquire a second lung cancer. So that's why it's important to continue the surveillance every year.
Okay, so let's go back to screening then. Where can I call, says this person, asks this person, to schedule a lung cancer screening? And can I get a screening paid for by my insurance if my smoking history is less than the 30 packs a year, which seems to be the guideline? Dr. Thur?
The best place to get information about getting into a screening program is to go on our website, which has a page devoted to screening with all the access and information. As Dr. Rodriguez was saying before, the indications for screening are likely about to be broadened. Certainly, the initial criteria, which we already discussed, has indicated that among that group, the results are quite good. But we miss a lot. We miss non-smokers. We miss people who are at a younger age or even an older age. We miss people who haven't smoked, whose smoking history doesn't quite meet the threshold for screening. But if you do meet the threshold, then under the ACA, you should be able to get a screening study without co-payments or deductibles. If you're outside the criteria, many insurers will cover folks who do not quite meet the published criteria. It's also, what is also available are fairly low-cost CT scans for folks who do not meet the criteria to qualify for reimbursement. You can get that information on our website as well and obtain a fairly low-cost out-of-pocket payment paid for scan.
I would also add to that the screening process is supposed to be a shared decision with the patient. So we are very proud of the fact that Sylvester has a navigation system that you basically, when you call in our main number to get a screening for lung cancer, you'll be referred to a navigator that's gonna interview you and talk to you about the risks and the benefits of screening. And then they'll be able to follow you to make sure the screening gets done well and you don't get lost in the middle of it, because you're supposed to have these 3 yearly scans. So I think Dr. Thur said that, that we're gonna broaden the criteria so more patients are covered, but you also have to have the screening done at a place that can follow you and guide you through the process.
I think it's also exceedingly important to have your scan done at an institution where there's the expertise involved in interpreting the CT scan, and perhaps even more important, the surgical expertise to be okay with following spots on your lung that are very unlikely to turn out to be cancers. So there's a certain degree of uncertainty in this process along the way that the shared decision-making process has to bring out and discuss. Because what we don't want is to overtreat people, to put them through unnecessary lung resections associated with morbidity and whatnot. That's unnecessary for the problem at hand. And again, to emphasize that most of the findings on CT scans done for screening purposes do not turn out in the end to be lung cancer. So we don't want to overtreat these benign processes.
Okay. There's a lot of lingo in these conversations sometimes from the experts, and this person asked, what does the word marker mean? Dr. Dewar, maybe you want to take this one.
Yes, I can answer that question. So a tumor marker is anything which is present in or is produced by the cancer cells or other parts of your body or cancer cells in response to cancer. And it can also be used to tell if it can be targeted, it can be used to treat it with targeted therapy. And it can tell us if a patient is responding to treatment or not. So if you see lung cancer, not all lung cancers are same. So what we can do is we can check the lung cancer for any biomarkers. Biomarkers are specific proteins that we can check in your tumor. by molecular testing, by genomic testing, by mutation testing in your tissue or in the blood, in the liquid biopsy. And if you're found to have a specific biomarker, which can be a mutation in the genes, you can get targeted therapy. Then the other biomarker that we used for lung cancer is PD-L1. So your lung cancer tissue can be checked for PD-L1 staining, and that biomarker can tell us how your response to immunotherapy will be, how you will benefit from immunotherapy. So in lung cancer, biomarkers, tumor markers play a big role to tell us about the response to treatment and to also guide us towards the therapy, to guide the treatment for patients.
All right. Let's talk about radiation then for lung cancer. And Dr. Yakeli, talk about which patients are eligible for treatment for radiation.
That's a great question. Radiation is a very important and fantastic tool for lung cancer. We discussed briefly one of the types of tools earlier on, which is proton therapy. That's just a type of tool that's available. And a couple of the other treatment approaches that have really expanded and have taken an important role in radiation therapy. And I'll try to answer one of the other questions at the same time that was placed in the chat about chemotherapy and the use of lesions in the brain, is radiation, especially with our new targeted way of delivering radiation, using stereotactic body radiation therapy or gamma knife or stereotactic radiosurgery in the brain. We can really precisely target with very high doses of radiation spots in the brain without the side effects that we used to see with whole brain radiation therapy very effectively. And the other role where radiation has really expanded its role, we're talking a little bit about immunotherapy, has been in the past when someone was dealing with stage 4 lung cancer where it's spread, radiation would take what we consider just a pain control role or to control bleeding. But now with immunotherapy controlling the cancer, what we're doing is studying, and we have this trial open at University of Miami, where we're studying the role of stereotactic radiation therapy to treat any and all of the spots that we see in the lung or elsewhere in the body with radiation therapy to ablate those spots. And we're evaluating for a couple things. Number one, is it going to even help and make the immunotherapy work better? But of course, by what we're seeing from other studies that have been published over the past year, as Dr. Rodriguez pointed out, a lot has changed even in the past year, is that by targeting more and more of these spots where in the past we'd say, all right, metastatic cancer, we can't really do much. But now by going after aggressively, really taking care of and customizing our care for each patient and delivering this precise way of radiation, we've been able to expand the amount of people we can treat, but much more important than that, we've been able to help people live longer and better. And I think that's really the goal that we're all moving towards, which is to try to help anyone dealing with lung cancer live longer and better. So radiation, again, its common approach has always been in the past, and the role would be to treat more locally advanced lung cancers in combination with chemotherapy or to palliate pain. But really, over the past few years, we've seen the ability to treat with very high doses, very precisely, allowing us to treat, number one, patients that have metastatic disease in a very aggressive manner, or not trying to put Dr. Villamizar out of business, but in patients that he can't operate on that have early stage lung cancer, in the past were considered not curable, and now we can cure them with stereotactic body radiation therapy. So it's really a new age, a new era, and we feel like we're only in the beginning, even though we're standing on the shoulders of giants looking forward.
Yeah, I think that Dr. Villamizar would not mind handing over that baton for the wellness of the population. So it leads us to this whole evolution of immunological treatments. Will we be replacing the traditional treatments of chemotherapy, radiotherapy? Where are we on immunotherapy and which patients are eligible for this, Dr. Rodriguez?
So immunotherapy really has changed the way we approach lung cancer. So Dr. Duar explained that one of the important biomarkers when we try to define the lung cancer is to define if it's a cancer that is very sensitive to the immune therapy. And the immune therapy is a completely different treatment. In the past, we have given patients chemotherapy that basically kills cells that are dividing, and to kill cancer cells, we end up killing red cells and cells in your mouth, and people have a lot of side effects that are related to the treatment because it's not very precise. Immunotherapy, it works in a different way. It's trying to stimulate your own immune system to fight the cancer. So it's a more holistic treatment. It does have some side effects because your immune system will be fighting the cancer, and sometimes it could lead to a lot of inflammation that could lead to symptoms. So we try to select the patients that will best respond. If you have one of these mutations that are biomarkers, you'll be eligible for targeted treatments. Most of those are pills. All of those are pills. If you have a very high expression or immunotherapy of the marker that makes you respond to immunotherapy and you have advanced cancer, we will offer you now, and we have great data to say that we can actually we don't have to use chemotherapy, that immunotherapy by itself as a single agent will work best. So we now have two drugs that are approved as a single agent to be used by themselves to treat patients instead of chemotherapy. And there's new indications for combinations of immunotherapy. I'll let Dr. Duarte talk about how she uses immunotherapy with chemotherapy for her patients.
Yes, so whether a patient is qualified to get immunotherapy or not, and if you're wondering if you can get immunotherapy or not, it depends on many things. First, it depends on the stage. If you have stage 4, then yes, you are qualified to get immunotherapy. As a stage 4 lung cancer, you can either get a combination of immunotherapy and chemotherapy, or your oncologist can give you only immunotherapy, and that depends on the biomarker we talked about, the PD-L1 biomarker. If your oncologist notices that in your lung tissue, you have a high staining, high biomarker PD-L1, you may be eligible to receive single agent immunotherapy. Or if your oncologist think that you are too weak to receive chemotherapy, then you might be eligible to receive immunotherapy only without the chemotherapy. Then also in patients with stage 3 lung cancer, you can get immunotherapy after you complete your treatment with chemotherapy and radiation. So what does stage 3 lung cancer mean? Stage 3 lung cancer mean when the tumor is so big and it has spread in the lymph nodes in the chest, but there is nothing in the brain, there is nothing in the abdomen, it hasn't spread, but your tumor is, you're not a surgical candidate, or you are not, the tumor is quite big and you cannot get surgery. In those cases, the standard treatment is you get chemotherapy and radiation. After you finish treatment with chemo and radiation, if the tumor hasn't spread, you are qualified to get maintenance immunotherapy, which is called durvalumab, for 1 year. And that has shown to improve the survival and to decrease the recurrence in patients with stage 3 lung cancer. So, and there are also several clinical trials available. Now we are using more and more immunotherapy outside in clinical trials, outside standard treatments in patients before surgery or after surgery, but that is a part of clinical trial.
And what I will also add is that what has really been remarkable about immunotherapy is that for the first time, we're having discussions with patients who do really well in immunotherapy, that they have built an immune response, a memory to the cancer, and you can actually consider stopping the treatment, which is not something that we never considered before for patients with advanced cancer. And we already have seen significant changes in the 5-year survival of lung cancer just after the approval of immunotherapy. Someone asked in the questions, can you bypass chemo and radiation and go directly to immunotherapy? So Dr. Kelly will tell you that you cannot bypass radiation, and there's right reasons for that. I mean, radiation can be a curative treatment for patients with locally advanced cancer, and immunotherapy will be there to support the radiation, not to replace it. So we will, when we meet with you, we'll decide, you know, where it fits.
Okay, and piggybacking off of that, in that same chat, the person's asking, after immunotherapy, can a patient's mutations change? And if so, if new treatment is needed, would the patient need a new biopsy? That goes right after your discussion on this.
Dr. Duarte can answer that too.
So if a patient has received immunotherapy in the past and has also received standard lines of treatment, and when we are running out of option, when the tumor becomes resistant, then we do have an option to do a liquid biopsy if the patient doesn't want to have a tissue testing done, or when the liquid biopsy is negative, when we don't have any mutations in the blood, then yes, we can do a tissue biopsy to find out if a patient has a new mutation, or if a patient has a resistant mutation, or if a patient has a rare mutation, which will qualify the patient to be a part of the clinical trial, to use targeted therapy for clinical trials. So yes, there are options, and we do consider case by case basis, yes.
Let's throw our surgeons into the picture here. This person asks, after full recovery from robotic lung surgery with no further treatment prescribed, am I considered to have an underlying condition or not? The surgeons and anyone else in the group tonight.
Yeah, I think the question was related to predisposition to have complications with COVID, for example. So then the way that I tell my patients is that the fact that they already had cancer and had surgery, then they're gonna have decreased lung function. So they have to be careful, because if they get COVID and then it's affecting the remaining lung, then they are at a higher risk of having complications. But on the other hand, they would be a little bit more protected than, let's say, somebody who has active lung cancer and is receiving systemic therapy, like chemotherapy or immunotherapy or something like that.
Okay, anyone else on this one? Okay, let's talk about your thoughts on supplementing cancer treatment with a healthy diet. Let's talk lifestyle, avoiding sugar, fat, processed foods.
So that is a great question, because especially now that we're relying on immunotherapy and your own body to fight cancer, is very important and critical that people take care of themselves and they have a well-balanced diet. We have nutritionists and supportive services specialists that are here for you. So as part of your consultation, we will also offer a consultation with physical rehabilitation, because exercise is important to stay active. It combats fatigue from treatment. The diet, being a well-balanced diet that has antioxidants, that it has enough protein, enough calories through the day, that's gonna help you fight cancer. So yes, we want people to pay attention to their lifestyle. We want our patients to meet with our nutritionists and our supportive care services, which varies from, some patients use our psychology services to meet with a psychologist. We have meditation, exercise. We have support groups, which can be very helpful if this is a new diagnosis and you can meet with other survivors or patients who are on treatment. So during your meeting, sometimes we're going over a lot of information and we leave this to the end, but this is a very critical part of your treatment that we help you get through it. And all these things help: the nutrition, the exercise, the supportive care services that are offered at Sylvester.
I'd like to add, if I can, to what Dr. Rodriguez is saying, that there are times, especially when we're treating stage 3 lung cancer with combined chemotherapy and radiation therapy, that one of the common side effects is something we'll call esophagitis, or inflammation of the esophagus. It can get really tough to eat then. And at that time, and especially when people just need support. And what I mean by that is that sometimes their diet's not going to be perfect, or your diet's not going to be perfect, and give yourself a break. It's okay. People, a lot of times what I find is that the family members sometimes are much more passionate about having a great diet for the patient. And if it's something that the person going through the treatment really wants to do, then I think it becomes much more important. But if it's something that the family member really wants the person to do, I think it's important to give each other a lot of patience, and recognize that there are going to be times where it's going to be easier to have a great diet, and there are going to be times where it's harder. And just getting those calories down, if it's milkshakes, if it's Ensure, becomes really important. And that's where having the support and the team that we have at Sylvester, including nutritionists on board, becomes really important. And really, in a sense, you're meeting only part of the team here. I'll just share, there's radiologists, there's pathologists, so other doctors who are involved, pulmonologists, and then there's, of course, all our social workers and our nutritionists and others who are just involved in every step of the way, who, although not represented here, I feel very strongly what allows us to provide the best care is having that entire team with us, working together for you.
Dr. Villamizar, this question for you: what other issues do patients who have had lobectomy for cancer removal face, short, middle, and even long term?
It depends on the lung function of the patient before they undergo surgery. For someone who is active and is able to climb like 2 flights of stairs without any shortness of breath, having a lobe removed should have no consequences in terms of like the, his the patient's quality of life, being able to do all those things that they used to do before surgery. Particularly if it is done with minimally invasive techniques. Now, as any kind of surgery, there is pain associated with surgery just because it's like similar to when you have a cut in your skin, you're always gonna have pain. But with all these multi kind of like disciplinary approach to like pain control with different medications that are not addictive, like the opiates and things like that, local anesthetic and all that, the majority of patients after surgery actually have very good pain control again, particularly when it is done with minimal invasive techniques. Just a very, very, very low percentage of patients can experience pain that would last a little longer than just, a few days or weeks after surgery.
All right, let's see how many more questions we can get in because they're coming at us fast and furious. So we'll try and get to them all succinctly. And this is a question about targeted therapy. Let's talk about the difference between targeted therapy and immunotherapy.
Okay, so I can answer that. So targeted therapy is a cancer treatment which uses specific drugs, most likely pills in lung cancer, which target specific genes and proteins which are involved in the growth of your lung cancer. Targeted therapy plays a very important role in lung cancer because we have FDA-approved targeted therapies for lung cancer tumors for EGFR, ALK, ROS1, NTRK, MET, RET, BRAF. All these mutations can be tested in the blood and also in the tissue, in your lung cancer tissue. And if you have that positive mutation, you are qualified to get the approved targeted therapy. If you don't have particular mutation, then you cannot get targeted therapy, then you will get traditional chemotherapy or immunotherapy or combination of chemo and immunotherapy. And immunotherapy is not a pill. Targeted therapies are pills, usually, mostly on all lung cancer mutations. Immunotherapy is an intravenous treatment. It's a drug which goes into your system and stimulates your immune system to fight against your own cancer. It is not a targeted therapy, but it's a systemic treatment which is useful if you don't have any targetable mutations.
The other thing I would add is that the majority of patients that we meet, we don't know the target yet. So the most common when we do these exams, there are about 9 mutations that we actively look for because we have treatments that we know work, but those are really available for mostly non-smokers and about 15 to 20% of cases. However, that is changing every year. And I think that really the advent of DNA, better understanding, better techniques to understand the mutations, in the future, we will understand all the genes that cause cancer and hopefully have personalized medicine. That's the hope of personalized medicine, that you will have a targeted treatment for every patient and every mutation. So there's a lot of hope going forward. And we already know that this understanding these having better targeted treatments options is allowing our patients to live longer. The classic example, I think someone in the chat asked about Tagrisso, which is osimertinib, which is the latest drug approved for EGFR, and that's the genetic mutation that has been known the most and has several generations of drugs that have been approved. And we are actively working on research to get better at it, to target this mutation.
We have about 3 or 4 questions that we want to really try and squeeze in. So let's get to them as quickly as we can. And let's talk about genetics. So should my family be screened for lung cancer if there are multiple members with lung cancer in the family?
So the definite answer on that is hard because there is, we don't know about germline mutations. Like in breast cancer, there's BRCA1 and 2, which are mutations that you can track in the families and they lead to cancers. Lynch syndrome is another thing that leads to colorectal cancer, endometrial cancer, and this in the family. In lung cancer, there is a registry of families that have multiple members. the one thing that we have learned is that also some of the members have the same exposure. So the distinction between a genetic mutation that is in the family or a risk factor in the environment, like secondhand smoke or radon or something else in the environment, gets very murky. But there is data of evolving data and there are registries of family that have multiple members with EGFR mutations, but we don't have enough information right now to recommend testing in the family, because most of the mutations, all of the mutations that we know right now are not germline that are passed to family members.
So let's start moving into the direction of sort of early detection. Are there new developments right now that are detecting lung cancer earlier, allowing those signs to be visible so that you can attack it earlier?
Yeah, so I'll answer that because, precisely what we're trying to do with this awareness is that to make sure that the people who are at risk understand that low dose chest CT scan cures life by detecting lung cancer early. So it is important that everyone who smokes or who has quit smoking within the last 15 years and are within that age category that we talked about, 55 to 80 years old, that they insist on their PCPs to get a low dose chest CT yearly. That is the way that we're going to cure more lung cancer.
Okay, and again, to the surgeons, is minimally invasive surgery for lung cancer available at Sylvester now?
Yes, it has been available, for the last 20 years or so. Dr. Thotter was the one who started minimal invasive surgery at the University of Miami. We have done over 1,500 cases robotically. That was also Dr. Thotter who started the robotic program in 2008. And we do 100% of our cases robotically if it is early stage lung cancer. And even for complex cases after treatments such as chemotherapy, radiation, immunotherapy, we still are able to perform robotic surgery. But those cases are selected depending on how locally advanced the lung cancer is. So I'm gonna say over 80% of the cases, all comers, are being done robotically at the University of Miami.
Wow. So I think in a COVID year, this question has to be answered. A lung cancer patient who's been on an immunotherapy for 2 years, what about taking that COVID vaccine when it's available on a widespread, broad, for all of us, but for someone who is a lung cancer patient after immunotherapy?
So I will just add that, we are excited about the rapid development of a vaccine, and the University of Miami has been part of that work. There's a large trial at the University of Miami that is randomizing patients to the vaccine. And as healthcare workers that get exposed to COVID, we're also all eager to find a vaccine. When it's available, I think it will be something that all patients that are at risk, and lung cancer patients are very much at risk for COVID complications, they will be also the candidates for treatment. The only vaccines that we shy away from in immunotherapy are live vaccines, that this wouldn't be a live vaccine, like the herpes zoster vaccine. Those are vaccines that in the trials, they have excluded patients in the immunotherapy trials. But yes, we're all eager to see a vaccine for COVID, and our patients, like the flu vaccine, there are vaccines already that are there that you should get, the flu vaccine and your pneumonia vaccine every 5 years if you had lung surgery. And we already know that that prevents a lot of complications going forward for patients.
And Dr. Rodriguez, I'm going to ask you to share some closing thoughts as we shut down our forum. But I also ask that any of the physicians who might want to give contact information to patients out there do so on the chat feature. Like for instance, Dr. Aftab about the smoking cessation program at Sylvester to get a consultation and things like that. So go ahead and go in there and tell patients how to get in touch while Dr. Rodriguez takes us home.
Great. Well, thank you so much for joining us this evening. And thank you to the panelists who took time to be here with us, and really to the patients and the families and the caretakers who are listening to us. Lung cancer is the most common the most deadly cancer in the United States. It's the second most common cancer in the United States. And we really have to change the conversation about lung cancer. There's been a lot of stigma, especially because it's been associated with tobacco, and people have felt the stigma that, you know, they did this to themselves, that some patients have been not eager to get treatment or go early for treatment because of this stigma. And we really have to change that. And we hope that we communicated the fact that there's a lot of hope that we can screen patients earlier. There's a lot of hope that we can offer patients better radiation treatment that is less toxic, better targeted treatments, better immunotherapy treatments, and better clinical trials. And that's why we go to work every day, so that we can get you through the treatment and contribute to your cure, and offer you better options that have never been available. The other message I will communicate during Lung Cancer Awareness Month, besides the hope of the new treatments and all the approvals, is that we all have to become advocates for lung cancer. So every time I'm reminding, when Breast Cancer Month comes and everybody's wearing pink and out there, I'm always very sad that lung cancer patients don't get the same level of support. And that it's important to support our patients, but also important to speak out, because that's how we get more funding for research. And lung cancer affects a lot of patients in the United States and doesn't get as much research funding. So you can all become advocates for yourself and become advocates for lung cancer research, and help patients that may be high risk to go to their doctors to talk about screening. So we're glad that you're here. We hope we can do this again in live next time that we meet after COVID. And thank you so much for participating.
Thank you, Dr. Rodriguez. And I think maybe we'll have to work on the marketing message for lung cancer awareness. But thank all of you, the patients and families, for entrusting Sylvester and UHealth with your care. Please go to sylvester.org to learn more about virtual or in-person appointments, your choice, telemedicine, or come on into the clinics. They've taken lots of safeguards to make sure that you are healthy and safe. Don't forget to complete the survey at the end of this to provide some feedback. And in the meantime, bravo to all of you. Thank you, our experts. You were wonderful tonight. Thank you for saving lives. Have a great evening, everyone. Stay safe.
Thank you.
Thank you. Bye.